Dr. Raji is a neuroradiology clinical fellow and part of the NIH-funded T32 research program at the UCSF Department of Radiology and Biomedical Imaging. Dr. Raji completed his combined MD and PhD at the NIH-funded Medical Scientist Training Program at the University of Pittsburgh School of Medicine in 2010. He then conducted a postdoctoral scholarship in the Department of Psychiatry at the University of Pittsburgh before completing a transitional medicine internship at the University of Pittsburgh Medicine. Mercy Hospital from 2011 to 2012. Following this, he completed a 4-year diagnostic radiology residency at UCLA Medical Center. And Dr. Raji was funded in his PhD research as a predoctoral fellow by the American Heart Association and as a medical student by the Radiological Society of North America. He is currently funded by the Foundation of American Society of Neuroradiology. His research interests revolve around applying multimodal structural and functional neuroimaging to neuropsychiatric disorders and head trauma. He has published over 30 peer-reviewed papers on these topics in such journals such as Neurology, Human Brain Mapping, the American Journal of Preventive Medicine, and the American Journal of Neuroradiology. He'll be talking about brain health and imaging. Please welcome Dr. Raji.
Thank you so much for joining us on this pleasant evening and hearing me talk about brain health and neuroimaging. There it is. Okay. So this is William Uderholm. He is an artist who painted a series of self-portraits from the time as a young man in 1967, and then around 30 years later in 1996, he was diagnosed with Alzheimer's disease. And in the progression of self-portraits that he paints of himself throughout 1996, on through the year 2000, you can see the degradation of his artistic skills and the cognitive aspects of his ability to perform his craft. This is a very tragic but very poignant depiction of what Alzheimer's disease does to people, and it's very important for us to better understand all of the factors around Alzheimer's disease as well as what we can do about it. And what I'll talk to you about today is that many of the actual factors that we think are causing Alzheimer's disease or leading to Alzheimer's disease are actually modifiable. In other words, we can personally do something about them to reduce our risk for the disorder. And so Alzheimer's disease is the most common cause of dementia, affecting 33 million persons worldwide. On average, the total cost per person with dementia is much higher than even those who die of heart disease, cancer, or other causes. However, dementia, including Alzheimer's disease, can be prevented. This is a screenshot from a paper published in the Journal of Alzheimer's Disease in 2014, in which over 100 scientists from multiple countries around the world signed this petition from leading universities, including Harvard, Cambridge, and Stanford, to support the concept that a healthy lifestyle can actually reduce the risk for Alzheimer's disease by improving brain health and brain integrity. And I'll talk to you about some of the specifics of that in my work. But this is something that we're trying to apply as a field across neurology, neuroradiology, and psychiatry. And so the concept that Alzheimer's disease is something that can inevitably destroy people, we're showing is actually not always true, and that we can actually do something to actually prevent and reduce the risk for the disorder. This is a screenshot of a table from a paper published out of UCSF by one of my mentors, Dr. Yaffe, who looked at multiple risk factors for Alzheimer's disease and looking at the percent of risk for Alzheimer's disease as a function of each one of these risk factors. And so, what we see here is that around the world, the biggest risk factor for Alzheimer's disease is low education. And so right here, that's around 40%. Smoking is the next most common, followed by physical inactivity, depression, midlife high blood pressure, diabetes, and obesity. So each one of these factors are factors that can be either prevented, managed, or controlled. And so it's very important that up to 50%, as we see down here, of the risk for Alzheimer's disease is due to these attributable risk factors. Now, as we move to the United States, the risk factors are the same, but their relative importance is different. So top on the list is not low education in the US, but physical inactivity. So physical inactivity actually accounts for 21% of the risk, followed by depression, smoking, midlife hypertension, obesity, education, and diabetes. And that's 54% of the total risk. So little over half of the risk for Alzheimer's disease is due to multiple various lifestyle-related risk factors. And naturally, these are interrelated. So if somebody is depressed, they're not as likely to be physically inactive. If somebody's smoking, they're more likely to have hypertension. If somebody's obese, they're more likely to have diabetes. And if somebody has a low education, they're less likely to understand how all of these different factors can affect them. And so targeting even a 10% reduction in these risk factors can have a huge impact. And so it's estimated that if we can reduce the lifestyle burden by about 10 to 25%, we can cut the number of Alzheimer's cases by 50%. So what would that mean? That would mean over 1 million fewer cases of Alzheimer's disease in the US and over 4 million fewer cases globally just by addressing these preventable risk factors. And so like I said, in the US, lack of physical activity is number one, followed by, in education, it's number one worldwide. And so this is something that was published back in 2011, so we've had this data for a long time in terms of being able to apply it. Now, some of you might be thinking, well, isn't Alzheimer's disease inevitable? Isn't aging and degradation in the brain inevitable over time as it is in so many other parts of the bodies? Well, often it is, but not necessarily all the time. So this is one of my favorite case reports. In medicine, we never really draw this much insight from one case, but this was a paper published in the Neurobiology of Aging around 10 years ago now, and it was an autopsy report of then the world's oldest woman. So she was 115 years old at the time. At birth, she was only 1,600 grams. She was born prematurely. Her mother expected her to die and didn't take care of her, so she was raised by her grandmother, and she attended school, became a teacher, and outlived her husband and as well as her landlord. When she was 94, she got a really cheap rent in the Netherlands because her landlord didn't expect her to live that long, and then she outlived the landlord. So ultimately, they followed this patient for about 20 years. She agreed to have neuropsychiatric testing. She agreed to give up her brain to science to be autopsy evaluated. And what they found was that there was no trace of Alzheimer's disease in her brain whatsoever. There were no pathologic proteins or synapse loss or cell loss or shrinkage that they saw in her brain. And so in her case, she was well educated. In the case report, they also described that she was regularly physically active, walking several miles a day. She was an avid consumer of fresh fish. And so by following these lifestyle factors, even though she had a lot of things going against her in terms of her early life, she still had a very well-preserved brain with good function right up to the time she died after living over a century. So this whole concept that we can prevent Alzheimer's disease and maintain brain function even to very, very old age has given rise to the concept that I published on called cognitive health. And cognitive health to me refers to functional status in multiple domains of daily life, including your memory function, language, executive function, right? Can you remember a phone number? Can you plan your tasks out? And all of these factors that we express as cognitive behaviors are underlined by your underlying brain structure. So how is the physical size of different parts of your brain doing? What is the actual level of blood flow and synaptic connectivity to different areas of your brain? How will the different parts of your brain talk to each other? And then what is the presence in the brain of certain biomolecular markers like amyloid or tau that could reflect an underlying Alzheimer's process? So by understanding how brain health refers to cognitive health, we can have a full picture of how to actually optimize function and the health of the brain even into very late in life. And so what's the role of neuroradiology? So I'm a neuroradiologist, which means that I interpret medical images of the brain and spinal cord with various modalities, including magnetic resonance images, CAT scans, and my job is to understand how the different anatomy and function can be affected in various diseases to help support clinicians in making diagnoses of various diseases. And in terms of Alzheimer's disease, the classic role of neuroradiology has been very limited, mostly to rule out so-called organic causes of dementia, such as a stroke or a tumor. And this is based on guidelines from the American Academy of Neurology, which were published in 2001, but even as of 2017, have not been updated. So the gold standard of guideline recommendations has been published now over a decade and a half ago. But the purpose of imaging, as I'll show you, is to better use the various tools that we've innovated in that time to understand what are the biomarkers of function and structure that can help us understand who's at risk for dementia and what interventions might be helpful in reducing that risk. And so this is the practice parameter that I talked about, talking about the use of MRI in terms of a rule-out modality. But again, that was published in 2001, and it was submitted for publication in 2000. And so when you hear about best practices for imaging in Alzheimer's disease, individual practitioners are referring to this guideline, which is very, very old. And in that guideline, it talks about structural neuroimaging, either with a CAT scan or MRI scan, in the routine evaluation of patients with dementia. Other modalities, such as PET or SPECT, were deemed not appropriate at the time, and volumetric analyses, which I'll talk about a lot, was also at that time not deemed appropriate. But since that guideline was published, now a decade and a half ago, we've had over 11,000 publications in the medical literature about the application of more advanced structural and functional methods in Alzheimer's disease. And so the guidelines have not kept pace with the science, and that's why it's very important to talk to both practitioners and individuals who are invested in their health about what the actual advancements have been, which is also what I'll focus on today. So what are the best modalities for imaging cognitive health, for assessing the brain, to determine what the actual likelihood of Alzheimer's disease or other neurodegenerative processes are? And so we have different ways of imaging the brain in terms of the information we obtain. And so what you're looking at here are all brain images, taken with different techniques that emphasize various aspects of what we want to focus on as neuroradiologists. And so the T1 weighted image is focusing more on brain structure, looking at the anatomy of the brain as well as the relative proportions of gray matter, white matter, and CSF. And so, for instance, what we see here is the kind of gray matter cortical ribbon. We see that the white matter is between it and this fluid-filled area called the ventricles. These are the lateral ventricles. That's cerebral spinal fluid. Your brain floats on that, which is very helpful because it keeps your brain from necessarily bumping into something like a sharp bony ridge in your skull. And then we can look at brain structure using T2 weighted and FLAIR images, which help us look at pathology in terms of processes affecting both the gray and predominantly the white matter. If we want to get a more detailed look at the white matter in terms of the actual microstructure or very sensitive areas of pathology, we can use a technique called diffusion tensor imaging. And all these color-coded areas point to different white matter tracts in the brain that are oriented in different directions. So some go up and down, some go left and right, and some go backwards and forwards, interconnecting various parts of your gray matter and your neurons, which make up the gray matter. We can look at blood flow in the brain in terms of actually imaging how much blood is coming from your heart to different parts of your brain in a certain unit metric. We can look at fMRI, which tells us how much oxygen different parts of your brain need to extract from your blood to perform certain mental tasks. We can look at how much glucose or sugar is being utilized in the very basic cellular processes in your brain. And of course, we can also look at the pathologic proteins of Alzheimer's. This is an example of one with amyloid PET scans. And so there are all these different techniques, and the DTI on up through the ASL, MRI, and amyloid PET were innovated most heavily after those guidelines were published in 2001. And so the majority of papers on these different techniques have been published. I'll be focusing mostly on structural imaging because that is the gold standard that we currently apply as the first line in medical imaging right now. But it's not the be-all and end-all, and there are many different other techniques that, as we have more science and research, will evolve in the future. And so just because I'm focusing on one thing, it's important to realize that we have many other modalities that will be added on to this. And so in the future, you can expect looking at your brain structure, connectivity, blood flow, and we can integrate all of that into the best assessment because each of these different techniques gives us complementary information better than either one technique alone. And so when you look at radiology as a field, you can think of chest x-rays, CAT scans of the lung, mammograms for the breast, image-guided procedures to perform various sorts of interventions. But you ask yourself, what is the actual level of evidence in these individual areas? And how do we actually know what the evidence is for certain given medical tests or procedures? Well, in medicine, we have what are called systematic reviews or meta-analyses that can pool all the different papers published in a certain area and to evaluate what those papers show so that we can have a determination of what is the actual level of evidence that we're talking about in terms of what we're seeing. And so if a statin drug like Lipitor has 20 randomized clinical trials supporting its use, a systematic review would be a summary of all those clinical trials. And so what I'm showing you here is a table from a paper published in the journal Radiology, which summarizes the number of systematic reviews for different types of imaging tests in radiology. And what you see here is that in something like, for example, the diagnostic or technical performance of an imaging test near the bottom, we only have 4 or 7 systematic reviews. If we talk about screening use of imaging, which we have in mammography, we have 45 systematic reviews. But for neurologic morphometry or function, measuring the physical size of the brain with the techniques I'll describe, there are over 100 systematic reviews published. And so what that means is, for the volumetric techniques that I'm discussing, we have more systematic reviews published showing its use than any other technique that we use in all the different subspecialties of radiology. And so what I'm showing you is really now the application of what's been over 20 years of science. And as we always hear, there's a lag time between when you have the innovation of the science and its clinical application. And what I'll talk to you tonight is a summary of that bridge between the science and what we're actually doing in the clinic. So what is Alzheimer's disease? Alzheimer's disease is a neurodegenerative disorder. Neuro because it's happening in the brain, degenerative because the brain is suffering. And how is the brain suffering? It's suffering because there is shrinkage of vital parts of the brain that are responsible for memory and learning. And whether you look at the brain in any different plane, what you can see in advanced Alzheimer's disease is basically a smaller brain. So this is a healthy brain with a normal cortex, normal white matter, normal sized ventricles. And in Alzheimer's disease, there's shrinkage of the cortex, loss of gray matter, loss of white matter, enlargement of the cerebral spinal fluid. And that's important because atrophy is reflected by brain volume. So brain volume is like a vital sign for brain health. If brain volume is normal, what that means is you have healthier neurons that are functioning at more or less a normal pace. But if brain volume is reduced, that means that neurons are either dying or the ones that still survive are shrinking, and that is a component of reduced brain health that is a hallmark of neurodegenerative diseases such as Alzheimer's disease. And so as I talk about brain volumes into the evening, you'll start to understand that they are biomarkers of brain atrophy that happen in these disorders. So if we can detect them very early, that's important because we can then identify Alzheimer's before it becomes too advanced. And brain volume, as you'll also see, can respond positively to lifestyle interventions. In other words, brain volumes can get bigger in response to positive lifestyle behaviors. So a very important metric to keep track of as we go through the papers that I've published on the topic. And so this is an example, like I showed earlier, an axial section. Axial just means you're looking at top down. So we see the eyeballs right here, and we see the front of the brain. This is kind of the upper part of the nasal cavity, and this is the middle, and this is the back of the brain. So we have the ability to look very nicely at the structure of the brain and then to measure what's actually happening in terms of the size of different brain structures. And what do we do? Well, the fundamental science behind brain volumetrics goes back to a science called voxel-based morphometry. So when you take a picture on your phone and you look at that picture, which is very high resolution these days, you have pixels that make up different parts of the picture. And that allows you to distinguish different scales of color, shade. And what you see in imaging is that when you have a three-dimensional picture, you have what's called a voxel. So a voxel is a 3D pixel that can be used to measure different parts of brain volumes on a given scan. And what happens on an individual patient level is that you take an original brain image, you warp it into a common stereotactic space. So this is like a 3D grid system in a computer software program that allows you to compare different brains in the same area so that my brain is compared in the same system as somebody else's brain. And then we segment different parts of the brain into gray matter, white matter, and cerebral spinal fluid because those are the main tissue classes in the brain that make up brain structure. Then, once we modulate that field of warping, we can smooth it for statistical analysis. And so a lot of the studies I'm going to show you that I've published are based on this fundamental science. And there are different ways of analyzing the brain, but this is one of the most well-validated ones in the systematic reviews that I mentioned earlier. And the main area of application that we looked at was in the cardiovascular health study. So the cardiovascular health study is kind of like the Framingham study in that there were multiple individuals studied at different sites around the country for over 20 years. And they had assessments of their lifestyle factors, their cardiovascular risks, their cognitive function, and they had brain imaging done. So it was a very unique study because it combined all of that information into one data set that we could then analyze to better understand what was happening in these different individuals across these different sites in terms of their brain structure and function. And so the sites were in Sacramento, Pittsburgh, Pennsylvania, Hagerstown, Maryland, and Winston-Salem, North Carolina. And this was an NIH-funded study, actually. And this is the first paper that I published on linking lifestyle factors with brain structure. In this case, it was obesity and brain structure. And what we showed in this paper, this was in 94 individuals. On average, they were 78 years old. They were not only completely free of any cognitive decline or Alzheimer's disease at the time of their scan, but 5 years after their scan, based on the longitudinal nature of our study, we also knew they didn't have Alzheimer's. So what you're looking here is a relationship between the obesity and brain shrinkage, and it's not Alzheimer's that you're just detecting very early because these were supernormal individuals. But even in these supernormal individuals, we saw a negative correlation. So as body mass index went up, as individuals had more body fat, their brain volumes were smaller. And so we see that in very important areas of cognitive function in the frontal lobes, the hippocampus, as well as in the basal ganglia and surrounding white matter. So this was very important because it was one of the first papers that raised the possibility that obesity could be tied to reduced brain structure, and that itself could raise the risk for Alzheimer's disease, because if you have smaller brain structure, your ability to resist Alzheimer's pathology is impaired because you simply don't have as many neurons to lose. This is also important too because in another paper we looked at, we examined the actual other side of the equation, which was white matter. So white matter interconnects neurons and it can become abnormal. So individuals with chronic obesity, diabetes, cardiovascular disease can have, especially as they get older, these white matter hyperintensities that we can see. So all these white dots, these are abnormal because they reflect, in these individuals, long-term damage from chronic disease that shrinks the small vessels that supply the white matter and causes these kind of slow motion strokes over time of these areas. And what you see here is that as the white matter becomes more confluent or the different dots join together, especially in these posterior or back part of the ventricles, that means that the level of underlying vascular disease is worse. So, this individual might have some high blood pressure that could be fairly well controlled, but this individual down here with these more white spots can have poorly controlled hypertension, diabetes, and vascular disease over time. And what we found is that there's not only an increased risk of stroke in these individuals, but they also have an increased risk of brain atrophy. So what I'm going to show you is that as you have more of this white matter damage from chronic vascular disease, you have more shrinkage of your gray matter as well. And we showed that in this paper published in the Neurobiology of Aging in 2012, where we see that the white matter grade, the extent of those white matter hyperintensities, as that got worse, then there's more shrinkage of the gray matter as highlighted in the frontal lobes, the temporal lobes, as well as the occipital lobes. On the other hand, the relationship between age and the brain was attenuated. So what does that mean? That means when you account for the amount of vascular disease that an individual has, as reflected by the level of white matter hyperintensities, and you control for that in your mathematical analysis to look at that effect, then the age relationship between the brain and gray matter loss goes down. So what that means is age itself, in terms of the passage of chronological time, doesn't mean that you necessarily have to have a shrinking brain with worsening mental function. The only thing age means is that you're more likely to acquire vascular diseases that themselves are the cause of the brain aging and gray matter shrinkage. And that was a very important thing to reveal in this paper because many individuals hadn't necessarily thought of it that way before. But what about the other side of the equation? What happens if we actually have positive lifestyle factors? So if obesity is bad for the brain and chronic vascular disease is bad for the brain, then can physical activity or other lifestyle behaviors actually be helpful to the brain? Well, we tested that in the same cardiovascular health study, and what we found was as individuals walked a progressively higher number of city blocks, so about on average a mile a day, these areas you're seeing here now are actually areas of larger gray matter volumes, improved neuronal health, and individuals who are more physically active. And we looked at walking specifically because that's a very simple physical activity that almost anybody who's able to can participate in. So what we found here was that these individuals with larger gray matter volumes from walking had a lower risk of Alzheimer's disease 5 years after they had the scan, and a lower risk of cognitive decline as well. And so the lifestyle factor and its effect on the brain were that direct link. So if you look at the link between walking and Alzheimer's disease risk, that's a weaker link to draw. But if you're able to get the positive brain benefit associated with walking in the form of these larger gray matter volumes that we can see on the MRI and that we can actually measure, then you had the reduced risk of Alzheimer's disease. And that's a simple analogy because just like somebody with physical activity might have a reduced heart attack if their coronary arteries are clean, but if their coronary arteries are clogged, it might not matter how much walking they do if they don't get that positive biological effect in that sense. And so having that link that we can see on imaging becomes a very important value in determining the risk and stratification. And the main areas that benefited the most from walking were the hippocampus and the precuneus, two vital parts of the brain and cognitive function that are affected very early in Alzheimer's disease. So the areas that are the most at risk for Alzheimer's actually get the most benefit from the physical activity. And this was simply a replication of the prior two papers in 1,000 subjects. So this was the full multi-site cardiovascular health study database. This was work done in collaboration with UCLA's Laboratory of Neuroimaging back in 2015. And what we find here is that if you have a worsening body mass index, you have very impressive diffuse effects in the brain in terms of volume loss. If you have positive effects from physical activity, those also affect the hippocampus and different parts of the white matter. The bottom row is the most interesting to me because what it shows is that there are common parts of the brain that are affected jointly by negative lifestyle factors like obesity and positive lifestyle factors. And so if obesity is worsening the brain and physical activity is helping the brain, the common battlefield they meet on are in these shared areas based on the overlapping statistical effects. And so what that tells us is that there are certain key strategic parts of the brain that are vulnerable to modification from both positive or negative lifestyle factors, all of which we have control over. This work was separately replicated by a group in the University of Illinois. This was a randomized clinical trial. So they took 120 individuals in their 50s. They didn't have Alzheimer's disease. They were otherwise very healthy individuals. And they randomized them to two groups. 60 of them went into an aerobic exercise group where they did aerobic exercise 3 times a week for about 45 minutes. And then the other group was randomized to passive stretching. So they would stretch, but they wouldn't really move around that much. And then they measured their brain volumes at the start of the study and then 6 months and 1 year later. And what we see here is that in the blue bar, which is the exercising group, you have increased hippocampal volume at 6 months and 1 year. And both of these are statistically important or significant effects. Same thing with the right side. The passive stretching group, though, declined. So they didn't go up. They didn't even plateau. They got worse. Same thing on the right. The caudate nucleus and the thalamus were also assessed because those are areas of the brain that aren't really implicated in Alzheimer's disease as much. And what they found was that the people who exercised still did better, but not really as good as the hippocampus, because the hippocampus is the most plastic part of the brain. It is the most susceptible to change and modification from a variety of biochemical factors and lifestyle adjustments. So if you're exercising, your hippocampus, the most important part for your memory and the most vulnerable to Alzheimer's, is getting the most benefit due to its inherent plasticity, which we see in this randomized clinical trial, which is the gold standard of experimental design. What about diet? So diet we've heard talks about vitamins and different types of approaches for that. How does diet actually affect the brain? Well, this was a very nice study published by Fernando Gomez-Pinilla, one of my colleagues at UCLA, and it was a very elegant examination of the anthropology of increasing head size and brain volumes. So when you look at the evolution of human species from Homo erectus through Homo sapiens, what you find is that human skulls and thus the brains get bigger as different cultures settle in great river basins. So you think of the Nile in Egypt, or you think of the Ganges in India, or you think of the Yangtze in China. All of those different river basins spawn large civilizations with advanced cultures and technical achievements. And one of the hypotheses behind why that happens is access to seafood, omega-3 rich fish in those large rivers help these civilizations and thus our entire species to evolve larger brain volumes and thus larger skulls to support that, essentially giving birth to new human species. And there are many underlying molecular mechanisms for how this can happen. So diet plus exercise can modulate mitochondrial function, BDNF, which is brain-derived neurotrophic growth factor, which we see here in this box, IGF-1, insulin growth factor, and also reducing the amount of reactive oxygen species, which can damage cells. It can cause certain genes to be turned on and off to better promote brain health and neuronal metabolism. And all of these different molecular mechanisms together can help us achieve better cognition and, of course, better advancement of civilization in this case, too. So we tested that in the cardiovascular health study. We selected 260 cognitively normal individuals for which we had very detailed dietary information based on the National Cancer Institute questionnaire. And what we found was, as individuals ate more baked or broiled fish, most commonly salmon, they had larger gray matter volumes in the hippocampus, we see labeled in the arrows, and the orbitofrontal cortex, areas vital for cognitive function. And so now we've overlaid physical activity, obesity, and diet, which incidentally overlap very well with the risk factors Dr. Yaffe discovered in her neuroepidemiological work, with direct effects on the most important areas of the brain for cognitive function and thus Alzheimer's risk. And that's essentially summarized on this slide here. But one of the things that people talked to me about when I published this work was, well, I published about how walking can improve brain structure, but what about different types of physical activities? So suppose somebody likes bicycling or ballroom dancing or even gardening, for instance. And so we actually looked at different components of an active lifestyle purely on leisure. So leisure activities spanning a variety of different things from the dancing to the exercising to gardening to see if the sum total of those activities had a similar positive benefit on the brain. And we actually looked at the amount of calories burned just from these leisure activities over a 2-week period and then correlated that to the MRI scans that we then measured with the voxel-based approach. And so these were the activities we looked at: swimming, hiking, aerobics, jogging, tennis, racquetball, raking, golfing, bicycling, dancing, calisthenics. So raise your hand here if everyone here has done at least one of those activities or likes to do one of those activities. Okay, that's most everybody in the room. That's very important because if I'm telling you to improve your physical activity to reduce your risk for Alzheimer's, you're more likely to do that if it's an activity you enjoy, which is what this study was all about. If individuals are doing the activities they enjoy, regardless of whether it's in vogue or popular or something that anybody else does, is that going to have a positive beneficial effect on their brain? This is a very detailed analysis done on around 900 individuals, controlling for head size, age, gender, other lifestyle factors, and the study site. These were the individuals in the study broken down by study site. We see the average age is again 78. And what we find is that yes, if you have an active lifestyle from an activity you enjoy doing, you will also get a positive relationship with brain structure in many of the same areas that our prior data showed, including the hippocampus and the crosshairs, as well as the frontal, temporal, and parietal lobes. And what's that difference? Well, the most active group was burning 3,400 calories per week compared to the least active group, which is around 348. And the active group had 5% more gray matter than the inactive group. Now, 5% might not sound a lot, but when you consider how many neurons the brain has and how many neurons you would need just to get a 1% increase, that is a very, very powerful effect. And what we see here is that there was an increase in gray matter volumes even in individuals who already had Alzheimer's disease or mild cognitive impairment. Now, it didn't reverse their symptoms, but it did slow the level of cognitive decline. So the idea of taking individuals with Alzheimer's disease and putting them in nursing homes, often where they're very sedentary, is not the correct way to go about it. Activities, particularly supervised activities in individuals who are going to be at very low function, can actually have a positive effect on the brain as well, and at least attenuate or slow the level of cognitive decline. And this was a paper that we published in the Journal of Alzheimer's Disease reflecting all of these findings. So we've talked about Alzheimer's disease. We've talked about the different lifestyle factors that we can see directly affect the brain. But one of the big risk factors that we're increasingly recognizing for not necessarily Alzheimer's per se, but cognitive decline is head trauma. Head trauma is a very important factor in both athletic groups, professional athletes like football players, as well as in military veterans who've been exposed to blast exposure injuries in Iraq and Afghanistan. And so if we can have a better understanding of how these sorts of head traumas can affect the brain, that might be useful in determining another source of cognitive decline, because many of these individuals with chronic head trauma also think they have Alzheimer's disease. And so this is an example here that we published in the American Journal of Geriatric Psychiatry, talking about the actual change in gray matter over time. And what we see here is that the brainstem, and we'll show the specific images later on, but the brainstem is the most affected region. In this same patient, the hippocampus actually goes up by 5% because, as we'll discuss, this patient actually had a lot of brain-healthy lifestyle behaviors that helped. So think of this case as the individual patient example of all the different data that I showed in all those hundreds and thousand patients. And so brain structural improvements can be detected in response to interventions. The randomized clinical trial showed that earlier. And there's a combination of different sorts of activities and interventions that can help the brain. So this has all led to the idea of what I call preventive neuroradiology. So the idea of engaging neuroradiology as a tool, not just in sick care, when there are really bad health problems that are affecting what's happening to the patient, but also in actual health care in terms of preventative action pertaining to brain aging and cognitive decline. And so imagine for a minute if you were 50 years old, patient who wanted to walk in and get an assessment because they had either a family history of Alzheimer's disease or maybe some unfavorable lifestyle factors such as high blood pressure, obesity. Having a baseline assessment in the future could be very helpful in tracking any sorts of changes in cognition in the future and any underlying abnormalities in brain structure. And the ability to measure that can provide the patient a metric to track, just like we do with cholesterol in heart disease, for example, or in a variety of other illnesses. And so preventative neuroradiology is the concept that will hopefully evolve into a field and a subspecialty that will help us do just that. And actually, part of that's being done right now at the Cognitive Health Clinic at UCLA. So one of my collaborators, Dr. David Merrill, has a clinic that essentially looks at different causes of memory loss, because it's not all Alzheimer's disease. It's other factors that can also affect the brain as well. And if lifestyle is an important factor, knowing that and optimizing it earlier on can only be helpful in reducing the risk for Alzheimer's disease in the future. And so instead of dementia clinics or Alzheimer's clinics, we're starting to conceive this as cognitive health centers that can actually be focusing on how do you optimize the brain for maximal function as opposed to simply addressing it when things are already falling apart. And one of the ways we can do that now in the clinic is with a neuroimaging software that was actually developed with collaborators in Denmark, and it's FDA cleared. So everything I showed you earlier in terms of voxel-based morphometry, that's great for a research tool, but that cannot be applied in the clinic. That's designed for large-scale research studies, and it can't be necessarily applied as easily on individual patient subjects. But this software, called NeuroReader, can. And what we found in testing it is if you take the actual hippocampus, so this brain structure that we've been talking so much about already, and you measure it with Neuroreader, which is a computer software that isolates and quantifies brain volumes of different areas, you can actually get very good reproducibility compared to an expert anatomist. So what we're showing down here are what's called dice similarity coefficients. Dice similarity coefficients is basically a mathematical measure of how well do different measurements agree with each other. And what we see here is that on average, around 87% of the time, with a maximum of 91%, you have good agreement between the Neuroreader software and an expert anatomist. The only difference is it takes the expert anatomists 40 minutes to trace out the actual hippocampus, but it takes the computer program only about 2 minutes to do that. So for the purposes of clinical throughput and application, it becomes very helpful because you can have your scan and get your answer very quickly. And so that's what Neuroreader does. It's FDA cleared. It doesn't just measure the hippocampus, though. As you'll see in some of the cases I'll discuss, it measures other parts of the brain, and that's very helpful because if not everything is Alzheimer's disease, and Alzheimer's disease strikes the hippocampus, would it be possible, thinking together now, that other problems in the brain could affect other regions in terms of their volumes? And the answer to that is yes. And so this is an example of a Neuroreader report. It's very numerical. It's very granular. It takes a lot of analysis to understand what these numbers mean, and that's why it's very important that when you have this assessment done, you have somebody that's actually trained in neuroradiology to help you understand what's going on in concert with your neurologist, psychiatrist, or other brain health professional. But to summarize, what we see here are different rows and columns. The columns look at things like whole brain matter, different brain structures, so we see the hippocampus, we see the amygdala. The amygdala is actually very fascinating. It functions very critically in emotion, and the emotional regulation and encoding of memory happens in the amygdala. Your putamen is part of your basal ganglia. The thalamus, so all the sensations in the brain track through the thalamus. Have you ever watched a movie where they try to wake somebody up by holding some noxious smelling thing close to their nose, and then they wake up even though they're unconscious? That's because olfaction is one of the few sensations that doesn't track through the thalamus, but every other sensation does. And you need that sensory integration to understand what's happening with your cognitive background. We have the ventral diencephalon and the pallidum. We have examples here. So what you have, going back to this slide for instance, is you have your brain volume. You have your brain volume as a percentage of your TIV. What's TIV? It's total intracranial volume. It's the summary of your gray matter, white matter, and CSF all summed together. Now, why is that important? Because if you're going to say someone's particular brain structure is too big or too small, you need to be able to compare that in the context of how big their head is, because not everyone has the same head size. So if you can do that, that's a very important metric to account for in your calculation. So that's what the volume to TIV ratio looks at. Now, we have different indices. There's the Neuroreader index, there's the Z-score, there's the percentile. To summarize these different numbers, what they mean is they're comparisons of the individual brain structure to a normal database. That's important because if you're going to say someone's area of the brain is abnormally low or high, you need to compare it to a normal database. So what's the normal database? The normal database that is used in this software is a normal database from the Alzheimer's Disease Neuroimaging Initiative. That was a 5-year study funded by the NIH to scan individuals who were cognitively normal, who had mild memory symptoms, who had Alzheimer's disease. And the reason it's important is because those scans were very well characterized in these patients. They had very good technical quality assurance, and so you know for a fact that those controls didn't have Alzheimer's and that their scans were of high technical adequacy. And so we color code different scales of Neuroreader. So the kind of a mustard salmon color is abnormally low, and of course the color scales have been iterated over time, but basically they mean either normal, which is the black, abnormally low, which is the mustard, and we'll have different iterations of that. This is the summary of all of the abnormal brain areas. So the gray matter in this particular patient was 11th percentile of normal. Now you might think, well, that must mean that they have Alzheimer's disease. But what you'll actually find is that many people can have low gray matter volumes and not have Alzheimer's disease, because they can have other processes happening in their brain like vascular disease that can reduce their gray matter volume, but that's addressable, whereas the Alzheimer's isn't. And in fact, If you go back to this patient, their hippocampus was 39th percentile, and anything below 25th percentile is considered abnormal, and so ultimately this patient didn't have Alzheimer's disease in terms of their hippocampal volumes. This is simply another way of rendering the data, and so any of you remember having babies and having baby curves to see how big the baby's head was growing? And you would have different curves to look at if the baby's head was growing too big or growing maybe not as big enough. Well, this is essentially the same concept in these pictures, except it's showing curves of brain volumes. See how the brain volumes are doing. And so what we're showing here is gray, blue, and orange colors. The blue is normal, the gray is too high, and these dots here are in different parts of these curves. And so this is shown for the hippocampus and the different lobes of the brain, frontal, temporal, parietal, and occipital, as well as the lateral ventricles. Remember, if you're losing gray matter volume or white matter volume, what's going to fill up that space? Your cerebral spinal fluid. So if your ventricles are getting bigger, that's another indirect measure of brain atrophy, although as we'll see later, not necessarily the only effect. And so these cases don't project that well, but we'll do our best. This was a 61-year-old patient who had a chronic alcohol use, although we didn't know that when we actually got the scan initially. And he was concerned that he had Alzheimer's disease. He was having memory problems. He didn't feel as sharp as he used to. He was otherwise a very high-functioning professional, but he had this concern. So we scanned the brain, and what you can see is this is the sagittal or side view of the brain. This is kind of the front of the brain. That's the tongue right there. These are the sinuses. This is the main white matter tract called the corpus callosum. That's the fornix. And what we see here is the back part of the brain, which is the cerebellum. Cerebellum is literally Latin for little brain. It has the most number of neurons packed into it than any other part of the brain per cubic centimeter. And what we see here is widening of the cerebellar folia, as pointed out by these red arrows, which indicates atrophy or shrinkage of the cerebellum. And sure enough, these colors that we see here on this earlier version of Neuroreader are all color-coded blue. They're blue because they're normal in this particular color scheme. And so the hippocampus is normal. Actually, in fact, his hippocampus is about 12 times better than the average hippocampus in terms of volume. So does this individual have Alzheimer's disease based on his cognitive symptoms? No, he doesn't. But he does have something else causing his memory problems. And we see that with the shrinkage of the cerebellum, almost 9 standard deviations below the mean. So when I looked at this case, I immediately contacted my psychiatry colleague, Dr. Merrill, I said, how much has this patient been drinking? Goes back and he queries the patient further, and the patient said, you know, I didn't know that it was important to mention that I was drinking a bottle of wine every night for 20 years. But when he mentioned that, that was actually very important, because instead of telling the patient you have this incurable Alzheimer's disease, we're saying, you know, you're drinking too much. You need to stop that. And if you stop that, that's going to be helpful. And oh, by the way, your hippocampus and temporal lobes are normal, so you don't have Alzheimer's. So the patient was simultaneously relieved to know that he didn't have the volumetric indications of Alzheimer's disease, and then also empowered to know that this was something he could actually address, because he previously felt powerless. And that is the added value that we can add from a neuroradiology standpoint, especially in the area of cognitive health. And so we rescanned that patient a year later, and we found that his cerebellum stabilized. He was no longer experiencing the symptoms as much. And that was an example of a very important way of using this imaging combined with a good clinical assessment to understand what's actually happening. One of the reasons he thought he had Alzheimer's disease was because he had a PET scan done at another institution that said that it was an Alzheimer's pattern. What we're showing here with a PET scan was one of those other modalities I showed you earlier, showing glucose uptake in the brain. Neurons love using glucose. If they're not using glucose adequately, that's because you're losing neurons. But what we see here is bright, symmetric activity of the cortex all throughout, and there's no indication of Alzheimer's on our re-review. So it's very important that your PET scans also get interpreted by individuals with neurotrained backgrounds and specialties. We're not sure if that was the case with this PET scan that was originally thought to have Alzheimer's, but looked completely normal to us at UCLA. This is just a picture showing the arrows, showing the normal temporal parietal uptake of glucose. Okay, so this is our second case. This is a 67-year-old woman with a diagnosis of Alzheimer's disease. Now, we're having a bit of an alphabet word soup here. You have MMSE, you have MoCA. These are simply cognitive tests. They're 30-point cognitive tests that are supposed to give you an indication of whether or not somebody has a cognitive issue. Mini mental state exam, or MMSE, is the most common one. And you see it a lot for cognitive assessments, but actually it was originally invented to identify how people were doing after getting electroconvulsive therapy or electroshock therapy back in the 70s. So it's a very, very old tool, but still used very commonly. This individual was ApoE4 positive, so ApoE4 is the risk gene for Alzheimer's disease. And on the original scan, we see that there's some volume loss in the parietal cortex, indicated by the red arrow, and there's some loss of glucose metabolism in that area as well, but it wasn't thought strictly visually to be a very impressive case in terms of the Alzheimer's pathology. But look at all that red that we see here. So on this iteration of NeuroReader, red is very bad. It means that there's abnormally low volumes. And what we see here is virtually all of the brain volumes are low, including the hippocampus, which is about 10 times less normal than it should be. And so this patient had not only Alzheimer's disease, but a more severe aspect of Alzheimer's disease than what was suggested just by visual interpretation alone. And virtually every area of the brain is affected. The parietal lobes, the temporal lobes, the cerebellum is affected as well, but in this case, taken together with the temporal, parietal, and hippocampal volume loss, we can be very confident that this is actually Alzheimer's disease in this patient. This is an individual who had cognitive complaints, but their MMSE was perfect, 30 out of 30. So that's it, right? Just send them home, nothing to see there, should be okay, right? Well, what we see here are reduction, white matter hyperintensities in the brain. This individual had a history of coronary artery disease. Remember earlier that I mentioned that white matter hyperintensities can be indicative of vascular disease, especially in the elderly population. And this individual did have atrophy in his brain. His brain was not normal. He has atrophy in the frontal lobes here and in the temporal and parietal lobes, but this is still not Alzheimer's disease because the hippocampus is normal. So what this individual had was brain volume loss due to chronic vascular disease. And it was leading to some perceptible cognitive changes. But even though the cognitive test didn't pick it up, the NeuroReader did, and that's important because then it made prioritization of his vascular health and heart disease of greater importance, but it's not Alzheimer's disease, which is also very reassuring. This is an individual, a 69-year-old with progressive memory loss and depression. So what we see in depression, so depression, as you recall earlier, is a risk factor for Alzheimer's disease. And what we see in depression is atrophy of the amygdala. The amygdala and the hippocampus are very closely connected in the brain. They literally sit on top of one another. And that's important because if your amygdala is abnormal, it can affect the emotional encoding of your memory over time, which is one of the explanations for why depression can increase the risk for Alzheimer's disease. And so in this case, this individual had long-standing depression that was also leading to concurrent Alzheimer's disease. But even though we see that and these other structural abnormalities, it's really helpful to establish the diagnosis of Alzheimer's disease across time. So if you have hippocampal atrophy or volume loss on one time point, you still can't definitely call it Alzheimer's disease until you scan yourself at another time point, because Alzheimer's disease is progressive. It should get worse. The hippocampal atrophy should get worse. And if it's not getting worse, it could be still Alzheimer's disease, but more likely it could be hippocampal volume loss due to some other less frequent causes that are still possible. So certain types of epilepsy can cause hippocampal atrophy, for instance. There's a benign form of hippocampal atrophy called hippocampal sclerosis, which is pretty rare, but it's been reported in the literature. So you really have to go the extra step of scanning longitudinally to make that determination. And so we did that. This patient had a 2014 MRI. And what we see here is that over the course of 5 years, her hippocampus went down by over 10%. Her amygdala went down by 25%. And so this is definitely Alzheimer's disease. There's no doubt about it because you see volume loss in the right regions and you see that it's progressive. And based on the distribution of the volume loss in the amygdala, we can say, okay, in this particular patient, one of the driving forces of risk for her Alzheimer's was the very poorly controlled depression. In this case, we had an individual with anxiety, depression, memory loss, and alcohol use. What we see here is atrophy of the hippocampus. This was a color scheme now using the salmon color for the abnormal areas. and we also see the temporal lobe and cerebellum. And so this is an individual who had Alzheimer's disease, but he also had some alcohol use at the same time, and we can see that the Alzheimer's disease is definitely more dominant. This is much earlier in the process because the hippocampus is abnormal, and so is the temporal lobes, but many of the other brain areas are still within normal limits. This is that football player I was talking about earlier who had a history of high school football play. It was estimated that he was hit 900 times in the course of a 3-year high school football career. And football is not played the same way now as it was back in the 80s when he was playing. There was not necessarily the same attention to detail or care towards preventing concussions then as there is now. And so especially the level of play was very aggressive, and he actually had at least one episode of a loss of consciousness. And so he was having irritability, concentration issues, and he was worried about having Alzheimer's disease. But what we see here is that only his brainstem is abnormal, like I showed earlier, and the ventral diencephalon, which sits on top of the brainstem, so they're very tightly connected areas. We can see on the actual scans atrophy of the brainstem visually. It's very subtle, but it's there. But his hippocampus went up by 5%. So even though other parts of his brain weren't doing well because of the head trauma, his hippocampus was doing better. So we actually asked him and his wife, what have you been doing? And he actually said, well, when the symptoms started, my wife put me on a very high omega-3 fatty acid diet, fresh fish, organic, 3 times a week, was doing exercise, started playing online chess to jumpstart his brain. And that improved hippocampal volume that we see is probably why this guy didn't end up institutionalized. It actually helped prop up the other parts of his brain that weren't doing so well. And so that's important because 5% over 4 years, that's not just due to retest reliability error. So when you get on a scale and get off, you know how the number changes? That's error in the scale. So the error for neuroreader is less than 2%. This is a 5% improvement. So that is a real effect that we're seeing in this patient. And so it's important because even though he knew he had head trauma-related brain damage, he was encouraged by the fact that he could actually improve another part of his brain that was vital for protecting him from Alzheimer's disease. And that was actually very empowering for him. This is an example of the football player's brainstem that I was showing earlier. This is an example of an NFL player with abnormal pathologic proteins called tau in the same area of the brain that's affected in football play. And this was published by my colleagues at UCLA and PNAS. Now, why does the brainstem get affected by football play? Well, what happens is when one football player hits another, there's a very sharp angular deceleration against another player's head, leading to the triangulation of force in the brainstem. That's why this football player's brainstem was affected, but not his hippocampus as much. And so that's important because the idea that different parts of the brain shrink differently in response to different conditions, whether it's vascular disease, trauma, or Alzheimer's disease, becomes very important to understand what these numbers are. And what we see here is that in this patient that I showed earlier, there's a pathologic correlation to amyloid and tau tangles, mostly tau that we see in the patient with football. And that's called chronic traumatic encephalopathy or encephalopathy. It's thought to be a unique brain disease to football players who have had multiple head traumas in this area. And that was actually discovered by Bernard Amalu at the University of Pittsburgh. This is just a slide showing the frontal lobe atrophy that was borderline in this same patient because the front part of the brain also gets exposed a lot in football play, and some kind of smaller, subtle findings that we can see in different parts of those areas. This is interesting. In the football player, we see holes in the white matter in the back part of the brain. The back part of the brain is actually very important in terms of the white matter because some of the most crucial cognitive information tracks through white matter in this area. And so, if your precuneus is San Francisco and your hippocampus is Los Angeles, then the 405 is the key white matter tract connecting the two. And that's essentially what we're seeing in this white matter here in the posterior periventricular area, and that's called a nexus. It is a nexus region, a critical point where you have a disproportionate amount of white matter being conducted for critical cognitive information. And so these holes aren't big, but because they're in a vital key part of your white matter, they can have a very impactful effect on cognition. And that was actually a discovery that was made by my colleagues at UCSF, showing the higher number of white matter connections in the light blue in these posterior periventricular nexus regions that were affected in the head trauma case. This is an individual with memory loss and attention deficit disorder who had asymmetric hippocampal atrophy. So again, this patient also had head trauma as well, which might have led to some of the asymmetric atrophy in the hippocampus. This is an individual who had memory loss and aphasia. Aphasia is when it's hard for you to form words. So you can't say the right words or find the right words. And so he had 9 motor vehicle collisions since 1983. The reason that's important is because he has atrophy in his temporal lobes on the left side, some white matter damage that could have been from the prior head trauma. And what we're seeing here is that he had asymmetric volume loss on the neuroreader in his temporal lobes. So traumatic brain injury can raise the risk for a special type of dementia in which it's very difficult to form the right words, called primary progressive aphasia. So again, it's not all Alzheimer's disease. It's very important to have critical assessments to understand what the various different causes can be. This is an individual case of an 82-year-old woman who had slow to reaction time. There was a mild global atrophy reported based on a visual assessment. So this is just a radiologist looking at the images visually and saying, I think this brain looks too small. But all of her brain volumes were normal on the neuroreader. So that's very important because just like we can miss atrophy because we can't detect it more sensitively, we can also overcall or overdiagnose atrophy if we don't have the right quantitative assessment. And so this patient actually had a normal brain from a volumetric standpoint, some scattered white matter lesions, but at age 82, that's not something to be necessarily worried about given the normal gray matter volumes. So this is an individual with well-controlled vascular disease. So if you have white matter lesions from vascular disease and it's well-controlled, you need not have brain atrophy. And this is one individual case of that, actually. This is an example, very important example, actually. So raise your hand if you've heard of normal pressure hydrocephalus. So normal pressure hydrocephalus is one of the few surgically correctable forms of dementia. It is frequently misdiagnosed as Alzheimer's disease, and the classic triad or trio of symptoms that you see is gait disturbance, so difficulty walking, memory loss, which is of course very common in Alzheimer's disease as well, and urinary incontinence. And this was a patient who had, we'll go back to the numbers later, very abnormally enlarged ventricles. These ventricles are too big, but the actual brain itself does not look shrunken at all. And the ratio of how big her ventricles look compared to the rest of her brain is very skewed. We also see this jet of fluid in a part of the brain known as the cerebral aqueduct because there's too much CSF going too quickly in that part of the brain. So that's important because in this same patient, the neuroreader showed that the brain volumes in the lateral ventricles were 99th percentile of normal. It should be no more than 74th percentile. So the ventricles were very big, but the only part of the brain that was shrunken was the ventral diencephalon, and even then that was a fairly borderline metric. Hippocampus was normal, frontal lobes were normal, temporal lobes were normal, and so this patient had normal pressure hydrocephalus diagnosed after having been originally diagnosed as having Alzheimer's disease. And when they did a spinal tap, the patient got better symptomatically, and when they put a shunt in the brain, the patient dramatically improved. So this is one example about how volumetrics combined with other imaging metrics and good history can give you a better understanding of something that's actually not Alzheimer's disease, but correctable. So what does a volumetric report need? Well, it needs an explanation of what's driving the atrophy, right? Is it vascular disease? Is it head trauma? Is it Alzheimer's disease? Is it alcohol use? Is it a combination of factors? And if so, what are the dominant factors? And then what are some visual correlates we can look at? So I don't believe you should just look at the numbers and ignore the images. And I don't believe you should look at the images and ignore the numbers. You must combine both to get the best assessment. And hopefully these cases have been illustrative of that concept. And so you can imagine in the future a tool that can allow delivery of this information to various clinicians and patients. And we're continuing to fund research in how brain structure changes in Alzheimer's disease through the foundation of the ASNR, which is the main funder of neuroradiology research. So if you want to have any interest in supporting research, this is the main funding arm of our society. I'd like to thank all of my team members, mentors over the years at UPMC, UCLA, and UCSF. This is a big, big international effort, and of course, it relies on the support and understanding of everybody involved. And as individuals who are invested in your health, thank you for your time and coming to listen to me.
Where did Larry go? Oh, okay. And so, time for some questions? Anybody have any questions? Okay. Lots of questions. I'll try and take them in order, but...
When you went through the risk factors, you never mentioned anything about diabetes, blood sugar, A1C. Are there any direct correlations there? Because there's an idea that Alzheimer's is type 3 diabetes.
I know, I was actually on the initial web chat that suggested that back in 2005. That was before social media really hit it big, so it was kind of rudimentary. But going back to the initial part of my talk, I can actually show you that data, because I did overview it, although it might have gotten lost in the shuffle. Okay, so right here we actually see that diabetes is one of the major risk factors, both globally as well as in the United States. And the theory behind why that happens was originally amyloid-centric. So it was thought that you have insulin-degrading enzyme, which breaks down insulin. It also breaks down amyloid in the brain. And so if you have a hyperinsulinemia, too much insulin in type 2 diabetes, the insulin can't break down the amyloid. The insulin-degrading enzyme can't break down the amyloid because it's too busy breaking down the insulin. And so you have accumulation of amyloid by that mechanism. And actually, inhaled intranasal insulin degrading enzyme is being tested as a potential treatment for Alzheimer's disease on that basis. That work's being done by Suzanne Kraft at University of Washington, and the initial pilot results have looked very interesting. But on top of that, the other major mechanism by which diabetes causes problems in terms of Alzheimer's risk is by affecting blood flow to the brain, vessels, causing small strokes, and that's more along the vascular component as well. And so I think the two major components of diabetes is insulin actions on amyloid, as well as the separate vascular risk that can sometimes cause cognitive problems, but not Alzheimer's. So not all diabetics can have Alzheimer's disease, but many diabetics will have cognitive decline that can be better addressed by the proper control. We actually correlated hemoglobin A1C with the brain volumes, but we didn't find any relationship in my initial studies. And actually the diabetes effect, there was an effect of diabetes on brain structure, but when I controlled for the obesity, the body mass index, that diabetes effect vanished, which means that it's the underlying obesity leading to the diabetes that's by far the driving factor. Now, why is that? Because adipose tissue, fat tissue, is a huge pro-inflammatory organ in large amounts. And so the inflammation mechanism then becomes of vital importance. And many individuals think that a lot of Alzheimer's is chronic, low-grade, unremitting inflammation from factors like very excess adipose tissue.
May I ask another diabetes-related question while you're still on it? Would that be okay? Thank you. I thought I understood that the problem with this type 3 diabetes was actually the metabolism of glucose and the ATP transfer problem that goes on cellularly. Could you speak to that?
Yeah, so what you're referring to was actually the initial papers published in the late 90s at the Mayo Clinic looking on histopathological samples of diabetics with Alzheimer's disease. And what they find is that individuals with diabetes have what are called advanced glycation end products, or AGEs. These are thought to be byproducts of cellular metabolism in neurons affected by diabetes, where essentially the glucose metabolism is so skewed at a dysfunctional level, so the mitochondria aren't functioning appropriately, there isn't a proper milieu of metabolism on both sides of the cellular membrane, that these advanced glycation end products are produced, and they're kind of amyloid-like proteinopathies, abnormal, misshapen proteins that then accumulate and essentially become cellular junk, thus leading to cell death by a different mechanism. And some people believe that in some forms of amyloid you can have incorporation of advanced glycation end products. So some people think they could contribute to amyloid by that mechanism. So that was actually how the field originally got started. Then it moved on to insulin-degrading enzyme, and then the effects there in terms of amyloid clearance, and then, of course, the vascular question, which also causes a lot of independent brain atrophy as well. But there's been no drug targeted towards the ages because the ages are intracellular, and it's very hard to get drugs inside the actual neurons themselves. One of the reasons why you see so much drug trials for amyloid is extracellular. So it's thought you can better target that. But I can tell you that none of those trials have worked. So when you clear the amyloid, at best you will see empty parts of the brain where neurons used to be. But you're not going to be able to grow them back when you've lost that many of them. And so now they're trying to do more tau-targeted therapies, but they can't deliver it inside the cell. And tau is actually more correlated with cognitive symptoms than amyloid. So even though people still really hang on to the amyloid idea, it's like a sandbag. Right? If you have a bunch of sandbags, there's probably a flood going on, but that doesn't mean that the sandbags caused the flood. And that's what I think is happening with amyloid.
Hi, thank you so much. A few things that are kind of tied together. So going back to the activity piece, is that more about oxygen in the body? And I'm wondering about sleep apnea and Alzheimer's correlation, hydration, and going to the depression piece, is there a shallow breathing component, a microbial component? You mentioned the inflammation, but I just wondered, like as you were talking, there seemed to be a lot of potential for shallow breathing versus potential for highly oxygenated breathing with respect to activity and people who aren't depressed and that kind of thing. And I was wondering if there were any active studies around that and the impact of apnea.
There have been studies that have actually correlated sleep apnea with brain atrophy. And I have often wondered if one of the reasons why obesity is so strongly correlated to brain atrophy is through an independent mechanism of sleep apnea as well. So you have all this inflammation coming out from the extra adipose tissue, and you're not getting enough oxygen because you're apneic. So I think that there's definitely a component of sleep apnea. There's also a component to disordered sleep in general and risk for Alzheimer's disease. So have any of you ever heard of the glymphatic system? So the glymphatic system is actually your brain cleaning itself while you sleep. And it can clean out various toxins, including amyloid. But if you don't sleep properly, then you're not going to have optimal glymphatic function. And that can also raise the risk for Alzheimer's disease through the amyloid pathway. In terms of the exercise question that you speak of, the main mechanism is not just oxygen, but also BDNF, or brain-derived neurotrophic growth factor. And so when you exercise, the epigenetic effect leads to greater expression of BDNF and secretion. And literally, this stuff is like a miracle grow for neurons, which helps you sprout more connections between neurons, and neurons that wire together more closely are more likely to thrive and be of appropriate size and metabolism. And so ultimately, that's affected probably in depression because many individuals with depression are sedentary. They don't want to move or they don't want to get, and so these are all interlocking factors, but the key thing is they're also independent. So when you control for these different factors, no one factor destroys the other factor in terms of its importance, but they add on to each other.
What about just shallow breathing in general? Because I know that there are some people who really are deep breathers, and there are some people who are very shallow breathers. And folks that I know with more memory challenges also, for one reason or another, also tend to be more shallow breathers, I've noticed. So I'm wondering, is there any correlation or studies around that?
I don't know of a study that's looked at shallow breathing beyond the sleep apnea question, but your question does raise the idea that if there's some subtle kind of subclinical sleep apnea that might not be diagnosed, but there's
I'm talking like
shallow.
waking shallow breathing.
I don't know of any studies that have looked at that specifically in terms of brain structure.
Okay.
The role of toxins.
Hold on.
Oh, well, the role of toxins is something that I didn't even have time to get into, but that's
Well,
actually a
the
wonderful question.
common idea is aluminum may be the cause or is it influential? I see it's not on any of your lists.
You know, aluminum has had a lot of media press, but the evidence hasn't really borne aluminum out as much. However, mold can be very destructive to the brain. So mold exposure can actually cause own separate brain effects. And so that's actually a very important factor that's becoming increasingly recognized. And Dale Bredesen, who's one of my colleagues at the Buck Institute, actually argues that there's a whole form of inhalational Alzheimer's that's due strictly to molds and other similar toxin exposures. When I say toxins, I'm really including alcohol and drugs too. Right? If we say alcohol is not a health food and you can actually have toxic exposure, then those factors can count as well. So yeah, I definitely do think that there's a big component. So if you have somebody with a risk for Alzheimer's disease, twins for instance, they actually did this study where they have sets of twins. The twins with the toxin exposure were more likely to get the Alzheimer's than the twins who didn't have it, even though they had the same risk factors in terms of the genetic ApoE4 allele expression. So you have this intrinsic risk, and then your environment kind of pulls the trigger of that gun. And so that's a good example, actually, with the toxins.
A while back, I heard about prescription drugs that have acetylcholine in them. Isn't that a learning neurotransmitter?
Oh yeah, so the original hypothesis, this is actually a very wonderful question, and it's something I frankly should have brought up at the beginning of the talk, but the state of the art for pharmacotherapy of Alzheimer's disease is based on acetylcholinesterase, so acetylcholinesterase inhibitors. So acetylcholinesterase, the ACE is an enzyme that breaks down acetylcholine. If you inhibit that enzyme, you can then increase the amount of acetylcholine in your brain. And that's actually based on the cholinergic hypothesis of Alzheimer's from the 70s. So the best drugs we have for Alzheimer's are based on a hypothesis of the pathophysiology of Alzheimer's from the 70s, which is now almost 50 years ago, I think. And that's important because even though there is a part of the brain called the nucleus basalis of minor that secretes a lot of acetylcholine, acetylcholine itself, correcting that, doesn't cure Alzheimer's. So it does help the symptoms, but it doesn't actually cure the disease, which kind of like in the case of amyloid, actually it's way more successful than amyloid drugs. But it does show that there's more going on to Alzheimer's than just the acetylcholine or the amyloid. But you're right, it is actually the mainstay of therapy right now, even though the therapy is not that successful. And there are a lot of side effects too. So if you put somebody who has head trauma-related cognitive decline on an acetylcholinesterase, you'll cost them money, you'll give them side effects, and you won't help them. Sounds like a good practice. Yeah, you don't want to do that, so that's important.
What about all the pharmaceuticals, though, that are based on interrupting acetylcholine?
Well, that would be terrible. So have you guys ever heard of the Beers list? No? Nobody heard of the Beers list? The Beers list is a list of medications that individuals who are of a certain age or higher should not be on. And a lot of those drugs are really bad for cognitive function. And of course, those can actually interfere with the actions of acetylcholine, like you said. So Google Beers list. It's like beer, like the drink, but plural with an S. Look at that list, and if you find that you're on like many of those medications, try to find a way with your doctor not to be on them as much, because those will affect cognitive function over the future. So when I was an intern, we used to have a lot of people with delirium in the hospital. Delirium is just like kind of a really bad dementia on an accelerated course, but it's all preventable, and it was often due to really, really large amounts of prescription drugs that interfered with acetylcholine. So once you got them off of those drugs, they got better. And you would look at these lists of patients with 20 or 30 drugs, and half of them were acetylcholine inhibiting drugs, and you're like, wow, this is terrible. We got to get them off of it. And so there is really something to that, actually.
Hi.
Hello.
I was told that we should have some raw butter and coconut oil for your brain, and I wanted to know how much percent is the fat in your brain. Also, Eskimo eat seal fat. Do they have Alzheimer's there? And also, about 20 years ago, I saw a film about epilepsy, and then they cured a boy with high-fat diet. So is there something to do with the...
Was that Lorenzo's oil? Nick Nolte, Susan Sarandon, 1992? No? Okay. Well, anyway, sorry.
Yeah.
I think so. Okay. Yeah, so you're going way back into my 90s knowledge of movies, but to answer your question, most of your brain is fat, actually, and most of the benefits of omega-3 fatty acids come from their incorporation into cellular membranes. Now, it's funny that you mentioned the butter. We were actually talking about this at the dinner. David Asprey, who was one of the architects of the Silicon Valley Health Institute, talks about his encounter with, I think it was in Nepal, of this kind of yak butter. And when he had it as part of his coffee, it really improved his cognition. And so he tries to make some sort of equivalent to that here in the US. It sounds great, but I don't know if there are actual trials supporting that. But it would be a really cool study to do. So anything that you would encounter anecdotally may or may not have any of that evidence behind it. The seal fat in the Eskimo population, it sounds interesting. I don't know if the Inuit population is big enough to actually give you the neuroepidemiological data we would need to look at Alzheimer's risk. But that would be a very interesting study to look into. It may not be the case that they have a higher risk, but we would have to take a look at that.
And what about mercury, amalgam, and aluminum? Would they have anything to do?
Oh, well, that's actually a very important point. That goes back to the toxins question. So if you think you might have a cognitive problem, get tested for heavy metals.
Metal test.
Lead, mercury. Anybody know Tony Robbins, the famous motivational speaker? So Tony Robbins went on record publicly saying that he thought he had Alzheimer's disease when in fact he had mercury poisoning. Now the reason he had the mercury poisoning, you're not going to like this part, is because he ate too much mackerel. So mackerel is the one fish that's actually probably not that great for you because of the mercury exposure. So salmon is better, mackerel not so much, and that's actually what happened to him. The other question that I didn't entirely address earlier was infections. So Lyme disease can give you very similar symptoms of Alzheimer's disease. So Lyme testing is very important. Not everybody knows if they've been bitten by a tick. And actually, it's thought that herpes encephalitis, and herpes can actually increase the risk for cognitive problems and Alzheimer's disease as well because it's just dormant in the neurons for so long. But that literature is not as well fleshed out as the Lyme literature. So doing a full assessment to rule out all these things is important because you can't call something Alzheimer's disease for sure if you have these other causes.
So heavy metal test, hair test or blood test? Or
Blood test. Blood
blood
test is
test.
sufficient.
And how about the cavitation, root canals, all those?
Oh, well, I mean, that's important in as much as it's thought that the risk for bad dental health and the risk for bad vascular health are closely related. And so if your teeth aren't in good shape, you're more likely to have heart problems. Sometimes you can have infections that can go straight to the heart and cause a lot of inflammation there. And of course, if your heart's not pumping, you're not going to perfuse your brain. If you don't perfuse your brain, you're not going to have a healthy neural function. And so some individuals with cognitive decline have had histories of really bad infections of their heart. They've dropped their blood flow, and they're never quite the same after that because of that initial insult.
Thank you.
We have time for one more question. Tests?
When you only have one thing on health-related diabetes, and there's many, many causes, and one of the things that was really interesting is the protective effect of cholesterol, because in the Framingham study, the people who lived the longest in the old people's homes had cholesterols above 200. And so if our whole system is set up to kind of suppress cholesterol, how much of this brain disease is caused by having too low a cholesterol and not having the neuroprotective effects of cholesterol to build the brain and the fat that goes into the brain?
Wonderful question. Actually, very, very low cholesterol is correlated with depression, which itself is an independent risk factor of Alzheimer's disease. Anybody know the Eisenhower paradox? So Dwight Eisenhower had 9 heart attacks before he died in the late 60s. And after the first heart attack, he had this very aggressively low-fat diet. And then he had heart attacks 2 through 9 after that. So the more he tried to reduce his fat intake, the more heart attacks he got. So there's actually something to the actual cholesterol hypothesis. If you want a good book that overviews this, Good Calories, Bad Calories by Gary Taubes is a very good book that actually overviews the science, and he's actually a very good science journalist as well. It's Good Calories, Bad Calories, Gary Taubes, Taubes.
Okay, so we're going to take about a 10-minute break.